So I thought this was a pretty good medium.
Okay.
It's not tie-dye.
Yeah,
It's tie-dye themed.
Yeah.
Right?
I mean, this is actually, right? I got a couple of colors here.
You've got some tie-dye themes going. Did
yeah.
you wear it with that in mind, or you just picked out
No,
a shirt? But yeah, back to psilocybin. So what about the different doses for psilocybin? So that study that we talked about when it was terminally ill patients, they had a really big dose of psilocybin, right? But then there's other doses that have been studied too for psilocybin that don't necessarily have to give you a hallucinogenic or when you say subjective experience, is that what you're referring to?
Yeah.
Like a hallucinogenic experience?
Correct. From the user's perspective.
Okay.
Yeah.
So something that doesn't cause a hallucinogenic experience, you can also kind of come below that dose to psycholytic dosing. And then there's a dose below that that's referred to as microdosing.
Correct.
That's seems to be more of like a maintenance dose.
Well, it's a completely different model.
Right.
So your point is, and most of what we've been talking about, or what most people have been excited about in this country, is the psychedelic dose.
Right.
So these are the 20, 25, 30 milligram doses of psilocybin that give you that full-blown inward mystical experience. Right. You're fully out of kind of reality.
Right.
And then you've got your psycholytic doses, as you refer to, and those have been used primarily in the European model, where you're talking about maybe 10, 15 milligrams. So at the psychedelic dose, when you're under the full influence of that psychedelic dose, you're not having a conversation with your therapist. There's not much kind of back and forth going on. You're probably unable to talk.
Okay.
With a psycholytic dose, the idea there is to lower your defenses so that you can have a more honest, transparent, free-flowing conversation. Kind of loosen you up. Maybe it's like having a beer. Right. But you're still feeling something, right? You're hopefully feeling a little more relaxed. But the idea is to facilitate more conversation. And then the microdosing. So those are doses at which you should not feel, if it's dosed correctly, you should not feel anything at all. Right. And that's more in the model of our current, Prozac or Lexapro. This is a drug you take on a daily basis or every other day. Right. You're not feeling anything acutely, but over the course of repeated administrations, it has improved mood, and potentially cognitive benefits. Yeah. So those are kind of the three general models for which psilocybin or these drugs that have these acute effects can be employed. All the studies that I'm aware of, at least the ones that are furthest along in the clinical trial process, have all been investigating psychedelic type doses.
Okay.
So
like what's the differences like in terms of like their function?
Their function and perhaps how they're employed.
Exactly.
So one of the reasons why people are so interested in the psychedelic dosing is that it's limited in terms of it's 2 to 3 medicine sessions, what they call medicine sessions, and at least the preliminary data suggests that there's a sustained clinical effect just after 2 medicine sessions. Now, the caveat is in combination with psychotherapy, right?
Right.
But there's a package where there's a distinct beginning and there's an end.
Right.
And people don't do any treatment after that, and people are still better, 6 months out and potentially a year out.
Right.
So that's why they're so excited about that. The psycholytic dosing model, where you're taking these lower doses that are not necessarily so mind-altering, this has generally been done in the context of an ongoing therapeutic relationship with your therapist, one where you've been working with them potentially for years, you're going on a weekly basis, and at some point in your work, you hit potentially a wall, or there's some material that you have difficulty processing. Yeah. And at that point, the decision might be made, hey, let's try some psycholytic dosing of these compounds, and let's continue our therapy under the influence of that. And that's done maybe over another 10 or 20 sessions. Mm-hmm. And then once that's kind of complete and you've processed that material perhaps to everyone's satisfaction, you still continue the therapy with them.
Right.
So it's a lot more sessions. It's less kind of defined.
Right.
And that's potentially one reason why, at least maybe in our medical model, where sponsors have not been pursuing that.
Okay.
And then there's the microdosing.
Yeah.
So the microdosing, so there's actually much less research. There, as far as to my knowledge, there hasn't been any really randomized, double-blinded controlled trials that I've seen. And people might be running them now, but I have not seen any evidence of that. And then that perhaps is maybe a little bit less exciting because you still have to take it for it to work.
Yeah.
Once you stop taking it, presumably the effects kind of wear off. So it's just part of your, it's not offering that that huge shift that the psychedelic model is providing you in term as far as something in our toolbox that's different from what we have now.
Yeah.
But not to say it can't be useful.
Right.
I think that's an area certainly ripe for more research.
So I think also a question I ask myself when I'm just thinking about how the hell these things are working, right? Because certainly the analogy makes sense, right? Analogies make sense because they're relatable, right? But from a scientific standpoint, a neuroscientific standpoint, like, how are these things working? How are they having such an acute change in people's perspective on their disorder or mental health issues so quickly, right? There's the term neuroplasticity that gets thrown around a lot, right? But to my understanding, neuroplasticity usually occurs over an extended period of time, right? So whether it's a medication that you're taking over an extended period of time, whether it's therapy that you're doing over an extended period of time, that neuroplasticity occurs over that time period, right? But for it to occur in such a short period of time, could it be possible that there's like an accelerated neuroplasticity occurring? Is it something else? Because let's just state the standard of care right now for someone that comes into you with, you diagnose with a major depressive disorder.
Right.
You decide to put them on an SSRI and whatever other medication. You're not expecting to see for him to call you in like a week and say, hey, I'm feeling great. These are all the changes that I want to make to my life. This is all I'm ready to do. Maybe that has occurred, right? But it's not the typical case that comes into you after being a week on SSRI.
Right.
But potentially that could be the case with someone on psychedelics, right?
And that's a very exciting part. And so the example that you provide about people calling after a week or a couple of days, we have actually seen that with our traditional treatments.
Okay.
But that is certainly the minority.
Yeah.
Right. Those are a select few individuals, and it would be very interesting to see what's going on in those individuals, right? But that tends to be more the I don't want to say norm, but the expectation when you're treating with these psychedelics is that, yes, they're feeling better. Now, I don't know if they're necessarily ready to make these life-altering changes after a week, but they're able to certainly tell you, yeah, doc, I'm feeling, so much better. Right. But, this is not completely foreign to us, right? And so the use of ketamine, right, this dissociative anesthetic that's been around since the 1970s, caught on in the early 2000s in terms of its use in psychiatric populations. And here in Los Angeles, we have no shortage of ketamine clinics, right? Yeah. Folks providing IV ketamine. And this, what we call a rapid acting antidepressant. Yes, people are feeling better after 4 hours, certainly after 24 hours.
Is that a psychedelic?
So not in the traditional sense. There is certainly a psychoactive component to it. But the necessity of that psychoactive component is also an open question. Yeah. There are some studies associating the degree or magnitude of antidepressant response to how intense that dissociative response or dissociative experience was. Yeah. There are other studies showing that there is actually no relationship. But we know that in animal studies, administrations of ketamine, you start seeing more dendritic spines growing, which is actually indicative of neuroplasticity. So that neuroplastic kind of event actually can happen fairly quickly.
In ketamine?
In ketamine.
And in other psychedelics?
And animal studies for other psychedelics. That's what we've seen, yeah.
But is that the case with SSRI or standard of care therapy?
So not with SSRIs. So
I'm sorry, I'm just saying SSRIs, but that's sort of my term for like the standard of care. Yeah, I apologize.
So chronic use of those treatments, SSRIs, you do see actually increased arborization of those dendritic spines, but generally after we're looking like maybe 4 to 6 weeks. Right. Now, those individuals who after 2 days on an SSRI tell you like, oh my gosh, I'm feeling so much better, I'm changing my life. Those studies have not been done because those are unique individuals. We have no way to enrich for them. Right.
But with psychedelics, right? Those individuals are a lot greater in number. The incidence of those people are a lot greater, right?
Yes, absolutely. So those studies are easier to carry out because you've got those patient populations that are responding in a similar way. Right. So it's not to say that our standard treatments, can't do these things, they're probably doing them on a longer time scale, number one, which is not necessarily a bad thing, right? And fortunately, unfortunately, we're all about getting quick results, right? And sometimes that, it's necessary when you've got really acute situations, patients who are acutely suicidal. Yeah, you need to turn things around, quickly. But I think there's something to be said about, tried and true methods or treatments that definitely are safe and that have shown benefit. And maybe at the end of the day, they do have, a common coalescing or converging pathway that, yes, they're actually at the end of the day are doing the same things. Right. But maybe don't have that narrative or that experience tied with them. So that really goes back to the importance of the personal or subjective experience.
Because as you've told me before, and as I've read myself, that experience for a lot of people, a lot of people report that experience being one of the most meaningful experiences in their life, right? On par with the birth of a child or the death of a family member. Yeah. Right.
Yeah. So that's Roland Griffiths did a study with healthy individuals, and he looked at the subjective experiences of after I believe one or two administrations of psilocybin, and that's what people endorsed, right? And so the example I like to give is the disease model. So if we look at PTSD, one single experience with a really negative with a negative kind of context, and that affects you for the rest of your life. Unfortunately, that happens, right? That's what happens with PTSD, right? Could you imagine PTSD developing or occurring if you took the negative kind of aspect out of it? I don't know what that would look like.
So I get what you're trying to say, and I'm sure everyone else does, and it's an awesome point. It's an excellent point. I love starting from disease states and then seeing what's possible if you just flip it on its head, right? Which is sounds like what you're trying to do, which is like a PTSD, post-traumatic stress disorder. That doesn't really make sense, but a PTSD that's beneficial, right? Something that was such a beneficial event in your life and so life-changing that you just continue to relate the environment around you and how you go through life back to that event. Right.
Absolutely.
So that's what it sounds like you're trying to do. You're doing.
Yeah, that was beautifully put. So if you can imagine this, so if somehow you could dissociate for let's say PTSD, for example, and this is it's kind of a roundabout way of saying something. So follow me if you can. If you imagine disassociating the negative valence of that experience with maybe the neuroplastic events that are going on.
That's a great point. Let me interrupt you there, because a lot of people think neuroplasticity only in a positive sense, right? Because certainly there's neuroplasticity that occurs in PTSD, right? Because neuroplasticity, it seems like neuroplasticity develops secondary to your actions and the way that you think, right? So it's sort of a supply and demand is how I think about it, right? Where if you're constantly thinking a certain way, you're demanding your brain to increase that network connectivity in your brain, right? So in the context of PTSD, it's like you're constantly thinking back on this negative event, and there's neuroplastic changes that are occurring that are increasing the connections in your brain relating to that event, which are negative, right?
Yeah. So exactly. Neuroplasticity is not inherently good or bad. It's what you do with it, right?
Exactly.
And so in PTSD, yes, you have this life-threatening event, and your body responds by saying, okay, how do we protect you from that in the future? Oh, you have to be hypervigilant all the time, right? You have to think about the world as a very dangerous place, right? And so it shifts, and it's adaptive in certain situations. The idea is that, well, unfortunately, once you come back from the battlefield, if you don't kind of shift back, those changes that were made during, acutely after that trauma, can be maladaptive when you're living here in Los Angeles. Right. And so if you imagine if you were able to harness the neuroplasticity of that trauma without having the negative valence of that trauma, and then you sat with a therapist for, let's say, 40 hours, and that therapist told you the world is a dangerous place, you need to be hypervigilant, you need to look over your shoulder all the time. Right. Perhaps you could actually have that person develop a PTSD-like syndrome, right?
That would be unethical, Dr. D.
Right. No, absolutely. So this is it's purely hypothetical.
Yeah, that's a great point, though.
But you could imagine if you paired that with the subjective experience of having that highly traumatic negative valence trauma, that process would be so much more effective. Right. Yeah, that's an excellent point. So, turn that around to the therapeutic potential. It's like, yes, if I'm able to harness the neuroplasticity or incite that process, you don't subjectively feel anything. But then you sit with a therapist for 40 hours, and you guys would talk about, how to improve your life, all the positives in your life in terms of support systems you have with your family, your friends, all the wonderful achievements that you've made. Yes, potentially you could build a more adaptive narrative about yourself. But if you pair that with this life-changing mystical experience that you could really refer back to as that point in your life where things kind of shifted for you, you could imagine that would be even enhanced. So I think, in the future when we're able to kind of try to tease, if we have compounds that are able to elicit that neuroplasticity without the subjective hallucinogenic properties, we'll see that they're effective, but perhaps not quite as effective, or they don't quite have the durability, long term. So my one of the mantras I live by is that there's no free lunch. If there's always a cost to something. So the cost of taking out that subjective experience is that maybe you lose some of the long-term efficacy in a certain subset of folks. But one of the reasons why they wanted to try to disassociate the two is that the potential downsides of that non-ordinary state of consciousness is that in some folks who maybe have a predisposition to psychosis, that actually may elicit or cause a psychotic reaction.
So, in regards to that subjective experience, especially with a lot of these mental health issues, especially obviously PTSD. We're not just talking about PTSD, although this keeps coming up. But people's relationships with their friends and their family members are significantly affected. Their relationships with, I think, the universe in general, is significantly affected. I think their relationships with themselves is also significantly affected. And what I think that the hallucinogenic portion of this experience does is, what's repeatedly reported in them is an increased they feel that they're more connected with the universe, with the people around them, their friends, their family, their circle, right? And then they find a sort of a purpose in life potentially, right? Secondary to it. So I think it sounds like it's pretty required in the sense of like if you want to make advances in those fields. So imagine if you took away that narrative, right? Potentially again, you induce that neuroplasticity and you sit with a therapist, and they talk about your oneness with the world and with your friends and your family and finding a purpose. Potentially they could come around to that mindset, right? But this reminds me of the movie Inception, where, when you believe the idea comes from you, it's just that much more powerful. And during these psychedelic experiences, the type of therapy that they are employing is they use terms like inner directed, right? And what actually happens in session, at least with the MDMA, actually even with the psilocybin, is that, again, there's not a lot of back and forth while they're under the influence of the medicine. It's really about helping them turn their focus inward. What's coming up for you? What are ideas that are coming up for you? In the MAPS model, so this is the organization that's funding the MDMA studies. They're all about what they call the inner healing intelligence, meaning that all the answers to your challenges in life, things that are causing problems, you have all the answers within you already. The medicines, and it's the fear and it's anxiety that's preventing you from accessing those answers. The MDMA puts you in a space that lowers perhaps your amygdala activation, so that you can talk about those traumatic experiences and come to the answers yourself. And I think developing or facilitating that self-efficacy is a huge part of it. Right? It's no longer like asking your therapist for what the answers are.
The therapist is just there to help guide you that process so that you can find the answers within yourself.
Yeah.
And so, again, I think that's another element to it that's perhaps a uniquely human, that when you come up with the answers, that's supposed to them being fed to you, you just hold on to them that much tighter, and you just believe in them so much more.
And you're thinking that you gain that understanding from yourself with the hallucinogenic experience? Is that what you're alluding to? Or?
Yeah, I think the hallucinogenic experience is not absolutely essential. I think people can certainly come to that realization, understanding, or insight through other processes.
Yeah.
Even like meditation, right?
Right.
Those things take a long time.
Right.
Perhaps there's self-reflection.
Yeah.
But for a lot of folks, for whatever reason, one reason or another, that activation energy to come to that realization, you just need a little bit of a boost.
Yeah.
And that's potentially what the hallucinogens offer you.
Got it. Now, I haven't really seen a lot of studies that are head-to-head studies comparing any sort of psychedelic like psilocybin or MDMA against what the standard of care is. They did. I came across an MDMA and PTSD study where they looked at the effect of MDMA on PTSD symptom severity, and they noticed a significant reduction after I think 18 weeks, 3 sessions. I think you alluded to it earlier.
Yeah.
But significant reduction in with MDMA with psychotherapy relating to just psychotherapy.
Correct.
And they alluded to a study that had been done with the standard of care. I think it was an SSRI, and that the amount of symptom reduction in the MDMA with psychotherapy was greater than the study that had done the standard of care SSRI. Now, that's not a head-to-head study, so certainly you can't make any more significant of a connection just than that, right? Just than that observation.
So there is the one study from Robin Carter Harris again, New England Journal of Medicine, where he actually compared psilocybin plus therapy versus Lexapro or escitalopram plus therapy, and looked at the outcome at 6 weeks.
Yeah.
So that's not really the standard of care per se, in the sense that that type of psychotherapy is not the standard of care. But that's just the thing that kind of is the background, right? Because really the study was looking at the effects of psilocybin versus the effects of escitalopram.
Right.
And surprisingly, because I would not have anticipated this based off of the previous open label trials and the type of effect sizes we were seeing with psilocybin, right? But this was a nicely controlled study comparing standard of care with psilocybin. And actually, in their primary outcome, there actually was no statistical separation between psilocybin versus escitalopram. There was a 2-point delta, but that was not statistically significant. At least at the 6-week mark. They're following up those patients at the 6-month mark. So at the end of 6 weeks, there was no more treatment after that. So even the people on Lexapro were taken off of Lexapro.
Okay.
As we talked about earlier in our discussion, one of the aspects of psychedelics that people are so excited about is the durability of effect, the sustained clinical effect, that even after 2 sessions, you're done, but they're still staying well afterwards. We know that for people with treatment-resistant depression, if you take them off their SSRI, they will relapse. Right? Some will relapse at 1 month, some will relapse at 5 months. But if you look at all the percentage of relapse, it's certainly higher, over 6 months in the group that came off their SSRI. So
were they still on psychotherapy? I'm sorry to interrupt.
For this study, or
for the relapses?
For the relapses, generally they're. I have to go back and look, because. They're actually, you're right. They're generally not on psychotherapy.
Okay.
They just been on drug or not drug, and they stop. For this study, again, everything stops at 6 weeks. They're following up at 6 months. I think that's really where the money is. If really psychedelic and that model is really going to kind of prove itself, it's going to separate from the escitalopram group, because I would certainly expect people to relapse in those 6 months. Certainly some people will relapse in the psilocybin group, but hopefully not as many.
Yeah.
So acute, I mean, the acute outcomes were surprising that it did not separate. But we have to see the long-term outcomes. Now, the other thing to point out is that there's secondary outcomes, other outcomes that they specify. Those actually did separate between psilocybin and Lexapro. But again, these are secondary, right? So they're technically exploratory. If your primary doesn't come out, that's what you bet your money on. It didn't work, right? So who knows? If they had specified one of the secondary measures instead as their primary, perhaps,
What were those measures?
So the MADRS, and then the Beck Depression Inventory scales. And so those are actually more of our standard scales we use for depression. But they like the QIDS. And so they specified the QIDS, and there was no separation there. But if they had specified the MADRS or the Beck Depression Inventory, it looks like that there would have been a statistical advantage with psilocybin.
Okay, so it was noted in those secondary endpoints.
Yeah,
okay.
yeah, and another scale they used to look at functional outcomes. So we've been talking a lot about symptom reduction, right? But ultimately, at the end of the day, you not only want to just feel better, you want to do something with that. You want to function better. You want to start working again. You want to be interacting with your family and your friends, right? It's not just about your score on a scale going down.
Right.
And that's one of the exciting things about, and it's not unique to psychedelics. Certainly people who get better on our standard SSRIs functionally do better. But that's one of the exciting things about psychedelics is that, at least, qualitatively, what people report is that, yeah, my life has changed. I'm doing things differently that are just healthier for myself. I'm no longer, I decided that job in iBanking was, yes, earning me a lot of money, but was making me miserable. And so I'm doing something else with my life now. And so on one of those measures that looked at functional outcomes in that Carhart-Harris psilocybin versus Lexapro study, yes, that functional scale actually also looked better with psilocybin versus Lexapro.
Got it. Now, I think another interesting point, and a lot of patients that I have that are coming in, right, that have suffered a traumatic brain injury and have concomitant mental health issues, they, due to psychedelics not just being readily available anywhere, right, they end up going to other places, right, maybe the underground, and the underground being, a tribe in Peru, right? A tribe in Mexico, or I think there's even some tribes in the United States that the federal government has allowed to be able to administer psychedelics. I don't know I think it's ibogaine. It's not a psilocybin, but either way, right? It's a hallucinogenic experience. It's a psychedelic. And they come back and they say, that was amazing. That was incredible. It's really changed my life, right? A lot of the things that we talk about that people experience, and it's been beneficial for them. What do you think about that? And I'm sorry to interrupt you again, but I think what's really interesting, and we referred to in thousands of years ago in history, is the centrality of the shaman figure, right? That administers this sort of psychedelic experience and then guides you through the experience, right? Yeah. Which is basically exactly what we're describing when it comes to psychedelic associated therapy.
Yes.
Right? Someone that says, oh, what are you feeling now? How are you feeling about that? And sort of guides you along this process. Yes. So these psychotherapists that are administering psychedelics can potentially also put in their credentials shaman. What do you think?
Yeah. No, I mean, look, nothing that we're doing here is that innovative. We've been, I don't want stealing, but we've been taking influence. We've been inspired by what humanity has known for thousands of years. Right. Look, this has worked. This model has worked. We've just changed things around. We call our therapists and not shamans, right? But yes, the role of the guide, right, to guide them through that medicine experience. It's essentially what they're doing, and I think that's really where what the MAPS people have really kind of appreciated and acknowledged. I did the MAPS training myself, and then that was a huge part of the training process, was really appreciating, acknowledging kind of where this quote unquote wisdom came from. Right. And it wasn't the MAPS people, right? They were saying, look, we got this inspiration from what was going on for thousands of years and from these indigenous cultures. Yeah. So yes, we just kind of called it a little bit differently. We have credentials by your name. Yeah. You have to go to training. That's a little bit, and hopefully we're able to expand it to a few more people than just the shamans. Yeah. Right? I think in a indigenous culture, there's probably not shamans like all over the place. There's probably the one shaman in your tribe, the go-to shaman. Yeah. Unfortunately, that's not going to work here in the United States, where there's a huge amount of mental health need. Right. We're going to need more than just a few shamans around.
So you said that you went through the MAPS training. Yeah. And from what I hear, part of the MAPS training is to actually dose psilocybin.
Or remember,
Or to take the
they're
psilocybin.
MDMA, and then
Oh,
MDMA.
I'm sorry. Yeah.
Mhm.
To take the MDMA
Yeah.
so that you experience what potentially your patient will experience.
Yeah.
But you didn't get a chance to do that, or did you?
No. So I didn't get a chance to do that. So that's another active
Shucks.
question: is that does the therapist, do the practitioners need to have that experience with a non-ordinary state of consciousness to be an effective therapist?
Right.
And there's a lot of back and forth about it, especially in our little group. How many psychiatrists have actually taken an SSRI or an antipsychotic? Probably very few. Yet most of us prescribe it with no inclination or desire to see what they feel like. Would I be more effective if I knew kind of what acutely they made me feel? Perhaps, maybe the side effects. I could be.
All right. So you're going to tell me that there's no sort of curiosity in your mind regarding the psychedelic experience, like the curiosity in your mind regarding the experience is the same with SSRIs as a psychedelic?
Yeah. No, I mean, I'm very curious.
Right.
I'm very, very curious. So I kind of back to the question. I was digressing a little bit. Yeah. So is the experience of the therapist necessary? So yes, there is a component, what they call an experiential component, and actually MAPS in their earlier trainings, when this was before COVID, they actually had an FDA-approved protocol where they could dose therapists that they were training with MDMA.
Okay.
But when I took the training, this was right in the heart of COVID, and so everything actually was being done virtually. And so for their experiential component, what they did was a holotropic breathing.
Okay.
And so the idea is that not necessarily that you need to know what MDMA feels like, but probably that you should appreciate what a non-ordinary state of consciousness feels like.
Okay.
Right? And that they were able to achieve with the holotropic breathing. And it's not guaranteed for everybody that you'll go into that altered state. But for myself, it did. And this was essentially, you're essentially making yourself alkalotic.
Mm-hmm.
You're doing a lot of heavy breathing,
Right.
and you're probably raising you're probably raising your pH because you're blowing off all the CO2. Right. And I entered this altered state, and when I thought back to some traumatic memory I had, I really saw it from a different perspective. Had a very different emotional reaction than just thinking about it in this kind of ordinary state of consciousness.
Right. And do you think that you're thinking differently about that experience now, or you thought differently about it in the first weeks after or the months after? Like, what was that experience like?
Yeah, no, I certainly think I have more compassion for myself, or at least the 7-year-old version of myself. Right. That for someone to kind of witness that, it's like, oh gosh, it was, that was probably very difficult.
Right.
At that time, it was a little bit confusing, and even afterwards, when I thought about it, I was like, okay. That was kind of, I wouldn't have labeled it traumatic. Okay. Let's just put it that way. I wouldn't have labeled it traumatic because I was not involved and I witnessed it. But after I thought, my reaction to it during the height of that holotropic experience, my reaction was very different. It was much more intense.
Right.
And so now I think I wouldn't call it like a 180-degree shift. Right. I would say maybe it's like a 45-degree, maybe 75-degree shift. Right. But I certainly see it a little bit more differently, and I can appreciate maybe that it had a bigger impact in my life than I was willing to accept or maybe even notice.
Yeah, that's exactly what I was going to ask you. If it showed you how potentially it's impacted you in your current state. Yeah. That's really interesting. We might do some holotropic breathing after this podcast if you can guide me through that.